So I'm going to talk about my journey and the transition from multi-port VATS to uniportal VATS. And this is important, I guess, in America because really a lot of American surgeons have really embraced uniportal VATS. And as you know, there's a number of different approaches, open, mVATS, robotic VATS, and then uniportal VATS. And my background is that I'm a lung and esophageal surgeon. I do lung resection. I used to do lung resection with multi-port VATS, esophagectomy with laparoscopy and a VATS approach, benign esophageal work with the robotic or laparoscopy or endoscopy, and then the mediastinum with the robot. And then, I saw that Diego had developed the uniportal VATS really starting in 2011. Gaetano Rocco first did this in 2004, but Diego was the one who really drove this forward. And this became very popular in Asia and Europe. And then, as I mentioned, there's been very limited interest in uniportal VATS in North America, with most people saying, they ask why, in terms of doing this. And I've listed some of the surgeons who, in North America, who do uniportal VATS, and you can see it's really a handful. And so the question is, the advantages of uniportal VATS is it's a simple setup. You don't need expensive equipment. It may be associated with less pain and analgesia requirements, and it may be associated with less complications because you have less pain. And why should there be less pain? Because you have a single incision in the anterior part of the chest. The intercostal spaces are wider. With the robotic instruments, especially posteriorly, the instruments are banging on the intercostal nerves, or the trocars are. And I think that that kind of repeated movement on the ribs will result in probably less pain, and ultimately that may result into lower complications. Now, we tried to answer this question about, what's the best approach in thoracic surgery. And I was part of the ISMIC's consensus group, and where we looked at the data that was out there at the time and put together this meta-analysis. And we screened several thousand articles, and ultimately came down with about 145. I can't read it on this one. And so we had 145 studies that were selected. Only 7 were randomized. 138 were non-randomized cohort or case-controlled studies. And you can see that when all this, to be included, the studies had to compare one aspect of the endpoints that we were looking at. And so most of the studies were looking at multi-port VATS versus open, but we had studies that looked at multi-port VATS versus robotic VATS, multi-port VATS versus uniport VATS, and a couple of things, one study that looked at robotic versus uniportal. And so ultimately, we came out with 15 statements, and we looked at safety, oncological outcomes, function, and length of stay, and cost effectiveness. And when we looked, and the biggest difference, as you can imagine, was going from open to a minimally invasive approach. And most of the data that was out there was looking at multi-port VATS compared to open surgery, and we saw fewer complications, and there were significantly fewer complications. And that was, and then we saw this with several other endpoints when we compared any kind of minimally invasive approach to an open approach. But then what about mVATS versus rVATS? So in terms of comparing those two approaches, if we looked at complications, there was no real difference in complications between the two. So it's dealer's choice. You can either do robotic or you can do multi-port VATS. And then what about multi-port VATS compared to uniportal VATS? And we again saw no significant difference in complication between the two. Now, there weren't many studies out there, and I think a randomized trial would be great, but you'd need to have a lot of patients to look for small differences. But we did see some things some patterns with pain control and analgesia, which is where I think the most benefit comes with uniportal VATS. And at that time, this was the data that was out there. And if we look at VAS scores on the first postoperative day and then the third postoperative day, we can see that the VAS scores are significantly better with uniportal VATS. And if we then look at day 7 and day 30, at day 7, the VAS scores are also significantly better with uniportal VATS. But by the time you get to day 30, there's no difference between uniportal and multiportal VATS. I think it's still important that you have an early difference that supports uniportal VATS, because when patients get complications, it's because they can't cough, they can't move around, they may get more primary emboli. So I think if you can help those patients earlier on, they can get out of bed and they can move, I think it makes a difference, which, to me tells me it's, that there's something in it. And then when we looked at analgesia use over the course of 30 days, again, uniportal VATS kind of won out, and the patients did better with uniportal VATS. So, initially I was like Diego mentioned, when I first saw these cases, I was thinking, well, uniportal is something that only Diego can do. And then I started seeing the adoption in Europe, and I started seeing the adoption in Asia, and I saw the phenomenal number of cases that are being done in China. Sorry, this is a consensus statement that we had for pain control. And so I had the chance to do a sabbatical in Shanghai Primary Hospital, and we have some of the surgeons from Shanghai Primary Hospital over here. And you can see this is what the hospital looked like when this was built, and this is what the hospital looks like now. And this is the founder of Shanghai Primary Hospital, Dr. Yan. And initially, I think they treated a lot of TB patients, but now it's an amazing place. I wanted to thank, a lot of the key players. I mean, Diego was the one who introduced me to these folks, and really they've been nothing but welcoming and very helpful. And I think the collaboration has been great. You can see the volume of cases in Shanghai has just been tremendous. And in 2018, it was up to 12,000 cases. I think it's way higher now. And they had a bunch of firsts, and I can remember going to China in the 90s and visiting Beijing, and at that time, no one was really doing VATS at that time in the early 90s, and there were very few cases. But now it's, the Chinese are way ahead of what we're doing in the United States. So what did I learn from that? So first of all, I got experience with the uVATS technique, the setup, the exposure, figuring out how to use a stapler through the uniport and how to get those angles right. And I think the other thing is that I had to change the paradigm of the way I looked at the lung. So if I did a multi-port VATS, so I did laparoscopy, I'm looking at a top to bottom, where the head of the patient is at the top and the belly is down below and the diaphragm's below. But now I get used to looking at it from a front to back view, just like you do with a thoracotomy. I learned different ways of dissecting using, the harmonic or the ligature on one hand and the suction in the other hand, and then compared to using maybe traditional instruments like scissors and a pickup. And then for small blood vessels, using things like the Grenner clip or using energy for the small primary vessels, and then some techniques for doing some of the atypical segments. I saw some of the subxiphoid work, and I play with it, but I'm not at the moment completely comfortable with the subxiphoid techniques, but I use it every now and then. And as I said, with when doing the uniportal, the multiportal approach, you get used to triangulating towards whatever you're working with. And you sort of do that with the uniportal because as a surgeon, you have instruments coming from the right and from the left, and so you're not kind of having your hands together on one side and clashing. And so it was a useful experience. And I have to thank the folks from Shanghai Pulmonary for kind of really giving me that kind of deep dive and the exposure to this. And so I went back to the United States and decided to do uniportal surgery. And these are the results from our initial work, and actually our resident is here today, and we have just presented this as a poster. And this was a retrospective single-center study. We defined major adverse events using the general ESTS General Thoracic Database definitions. And we wanted to see if there was a learning curve, and we compared the outcomes between our first 50 cases to the later procedures. And we did statistical analysis using SPSS. Primary objectives were to examine perioperative outcomes, such as adverse events, length of stay, chest tube duration, adequacy of our lymph node dissection. And the secondary objectives were to look at survival and recurrence, and to just see again if we had a learning curve. So over a 40-month period, we've done 212 uniportal resections. The mean age is 68 years. Procedures are mostly lobectomies, but some segmentectomies and wedge resections, and I think only one sleeve resection in that series. The initial experience, we had 13 patients that had major adverse events as defined by the STS in the database, mostly pneumonias, and 30-day mortality was 1.4%. 17 patients required conversion, which is about 8%. But on those conversions, most of those conversions were to multi-port VATS. So you can always go to a multi-port if you need to do most things. And we had 7 that went to open. And the median length of stay was 3 days, and the median chest tube duration was 2 days. And then when I tried to look at learning curve, and I went with the first year, which was 50 cases compared to the rest of but I did also look at taking the median number to see if there was a difference, or the first 25, and the patterns were essentially the same. And taking the first 50, we found that the major complications were the same. If we looked at any complication, a grade 2, grade 3, any kind of complication such as a UTI, there was no difference between the two groups. And I was concerned that maybe we'd see more prolonged air leaks as I learned how to manage the fissure in patients, and maybe I'd see a few more air leaks in the early series, but really no significant difference in prolonged air leaks. And the only thing that really improved was the number of nodal stations that I was getting to. And I think I just kind of spent more time taking the nodes. And the number of lymph nodes was about the same. But we did see an improvement in the number of nodal stations. And then when we looked at overall survival, you can see that it looks pretty reasonable for a series. And these are not just stage 1 patients. These are stage 1, stage 2, stage 3, and include a few neoadjuvant cases that receive chemo and immunotherapy. And when we looked at disease-free survival, we saw also these findings. So, I think the transition from multi-port VATS to uniportal VATS, we could do it safely and feasibly. I think it requires commitment, and if you're someone who does any kind of minimally invasive approach, and then you see something else coming along your way, you have to say, well, why should I do this, and what are the advantages? Am I willing to commit to that? And we all like to do things that we're used to doing, and we all like to kind of see if we have good results, we don't want to ruin those results. But I think doing the deep dive and spending time in Shanghai was amazing, and it's an experience that I'll take with me. And really, I was an experienced multi-port surgeon before, and so except for the lymph node dissection, I really didn't see a big difference in learning curve, and I couldn't show that there was that. Now, maybe it was because I also spent time in Shanghai again. And I think oncological outcomes are acceptable. Now, I'm kind of looking at what Diego was doing with the robotic uniportal VATS, and I'm kind of like thinking, okay, maybe it's time to dive into something else. And it's always fun as surgeons to kind of look at what's out there and reinvent yourself every so often. And I think that's what keeps us alive and keeps us going. And so I'm going to stop there and thank everyone for your attention.